Hi friends, I welcome you all to the session of Conservative Dentistry and Endodontics question paper discussion. Today we are going to discuss the previous year question papers that is coming under the topic of fundamental tooth preparation and bulb protection. Why I have taken this is the most asked question, that is why I would like to give you a detailed description on the answers. So these are all the frequently asked questions that is being taken from the previous years on question papers that comes under this chapter. Basically, it has been the main focused question is the fundamentals of tooth preparation that comes as a long essay, then as a short essay and a short note. So I'm going to give you a detailed description of these answers. So this is the detailed flowchart of how to present an answer for a long essay and a short essay when it comes to fundamentals of tooth preparation. And kindly note my answer has been referred from 5th edition of Sturtevant's Art and Science of Operative Dentistry chapter 6, and the content starts with definition. You must be all familiar with the definition of tooth preparation, that is the mechanical alteration of defective, injured, diseased tooth such as placement of restorative material, re-establishing the normal function and form, function and aesthetics, that is given in page number 2833. Then you can discuss about what are the types, that is the conventional one and the modified one. Conventional can just give a briefing about conventional that requires a precise tooth preparation, specific wall forms, depth and marginal forms. Then it is commonly used in amalgam, cast metal and ceramic restoration. Then you can talk about the modified one, modified tooth preparation that do not require precise form or specific wall forms, depth and retentive features or marginal. This is used in composites and GIC. However, when you come to the fundamental concepts of preparation, fundamental concepts is actually the 5 points which is applicable to both the conventional and modified. You can say the first one is removal of all unsupported enamel tooth structure. Second one is fault, defect or caries is removed. Third one is the remaining tooth structure if it is left as strong as possible. Fourth one is to protect the pulp, and fifth one is the restorative material must be retained in a strong aesthetic and functional manner. And after that you can just give a brief description about what are the need or reasons for restoration. One is prevention or repair of caries, repair or replacement of defective restoration, restoring the form function of the fractured teeth and congenitally malformed teeth. Then you can talk about the objectives of tooth preparation. Objectives of tooth preparation, it is also given in the textbook. It is given the 5 are the remove all the defects and provide necessary protection to the pulp, extend the restoration as conservatively as possible, then making the tooth preparation in such a manner that even under the force of mastication the tooth restoration should not fracture or displace, and allowing the aesthetic and functional placement of the restorative. This must be discussed under the objectives of tooth. You must be very thorough with this. And second, finally, the factors affecting tooth preparation. This is one of the most important short note questions that is being asked. However, in detail it is given in the textbook. It is discussed under 5 headings. That is, first one is the pulpal, periodontal and occlusal problems and other treatment. They affect the design of the tooth preparation and choice of material. Second one is the dental anatomy. Dental anatomy is direction of enamel rods, thickness of enamel and dentin, size and position of the pulp, the relation of the tooth to its supporting structures. Then another one is the patient factors also play. One is aesthetic concern. Second is the economic status. Then you can tell about the medical condition. When it comes to medical condition, sometimes patients do require special position, shorter, less stressful appointment. For example, older individuals, they need restorative treatment, especially on the root. And you can tell about the primary objectives of operative dentistry is to repair the damage from dental caries or trauma while preserving the vitality of the tooth. That is the prime objective of tooth preparation. And choice of. So these are the factors. This must be discussed under this heading. Then coming over to the classification of tooth preparation, this must be a very thorough. You must be very thorough with this. That is a classification that was given by G.V. Black for class 1, class 2, class 3, class 4 and class 5, class 6. You must be thorough with all ones. You must give a detailed description about what are the classes. Now coming over to the stages of tooth preparation. The stages of tooth preparation can be discussed under initial stages of tooth preparation and final stages. I have given the page and numbers alongside. So these is the steps of initial and final stages of tooth preparation. You must all be familiar with all these 9 steps. So I'm going over to the first stage, we are all familiar, the outline form and initial depth. The introduction should start with definition. We must be familiar with, that is, placing preparation margins and cavity margins in position, so they will occupy the final preparation and prepare this given in the Sturban textbook. The key points is initial depth of 0.2 to 0.5 mm below the dentin enamel junction, positioning the enamel, that is 1.5 mm from the central pit of fissure or 2 mm from the prepared facial or lingual walls. And another point to be jotted down is initial depth of 0.8 mm in the cavity at the root surface. Then after definition, you can tell about the principles. Principle is all unsupported or weak and friable enamel should be removed. Then all faults should be included. All margins should be placed in a position to allow finishing of margins. Then you can tell about the what are the factors that are affecting the outline form. Is also, you must be familiar with it. It is already given in the textbook. That is described under 5 headings. That is extent of carious lesion defect, then aesthetic conditions, occlusal relationship, adjacent tooth contour, and cavo surface margins. And you should tell what are the features. What are the features? Why do we create an outline form? Also, you can tell like preserve the cuspal strength, preserve the marginal ridge strength, minimizing the facial lingual extension, or connecting two close, that is, which is for example 0.5 mm apart defects or cavities, or restricting the depth of preparation into dentin. This is why initial outline form and initial depth is being given. Then coming over to the primary resistance form, you must all be familiar with the definition. It is given in page number 304. And the key point is the pulpal and gingival floors are the one which resists the forces of mastication and prevent the fracture of the tooth or restoration. And you must discuss about what are all the principles. That is, principle is the first one is using a box shaped cavity with horizontal floor, restricting the enamel walls to allow cusp and ridge areas with sufficient dentin support. You can tell rounding of the line angles, then reducing or covering weak cusp or extending the cavity to include the weakened tooth, and then providing enough thickness of the restorative material to prevent its fracture under load. And you can tell about the bonding the material to the tooth structure when it is appropriate. And you can tell about what are the factors also which actually supports the primary resistance form. You can tell about the occlusal contacts and force, or the amount of remaining tooth structure. And you can tell the type of restorative material. When it comes under type of restorative material, you can tell about if it is the minimum occlusal thickness for resistance to fracture is amalgam, that is 1.5, cast metal is 1 to 2 mm, ceramics you can give be like 2 mm. Composites also, the thickness depends upon the occlusal wear. And you can tell about the bonding or restoration of a tooth. Now, what are the features of the primary resistance form also? It is also given in page number 304. It is like the box features, box like shape. The weak tooth structure must be included. Then the cusp and marginal ridges must be preserved. The line angles should be rounded. The adequate thickness of restorative materials and cusps must be reduced for cusp capping if it is indicated. Then coming over to the primary retention form, we are all must be very thorough with the definition. Again, I repeat, first starting with the definition, you know that it is the form or shape of preparation which prevents the displacement or removal of the restoration by tipping or lifting forces. And you should talk about, after definition, you can tell about what are the principles there, especially for amalgam restoration in class 1 and class 2, then for amalgam restoration in class 3 and class 5, for composite restoration what do you give, and for cast metal, that is especially cast metal parallel walls, 2 to 5 degree of divergence per wall. That is, greater the vertical height of the walls, the more divergence is recommended in walls of path of insertion. And for inlay and onlay preparations also, you can say when opposing walls diverge outlay but only few degrees to each other, then wall of insertion path or line of draw is perpendicular to flow. So these are all the points must be included in primary retention form. Then coming over to the convenience form. Again I repeat, the definition is given in page number 308. It is nothing but the shape or form of the preparation which provides adequate observation, accessibility and ease of operation in preparing and restoring the tooth. However, procedures for obtaining the convenience form is occlusal divergence of the vertical walls for especially class 2 cast restoration, and extending the proximal preparation beyond the proximal contacts. Then after that, after discussing all about the initial stages of tooth preparation, you can tell about the final stages of tooth preparation. So again, the step 5, you should be first starting with the definition. You must say it's the elimination or excavation of the infected carious tooth or faulty restoration which is left after initial tooth preparation. Then what does it allow? It allows the affected dentin to remain in a prepared tooth. How do you Determine how much dentin is to remove is unreliable, especially because the soft, acute or rapid caries is similar to color to that of the normal dentine. Then you can talk about any remaining old restorative material must be removed if any of the conditions are present. You can say old material affecting the aesthetics of a new restoration, especially old amalgam under a new composite, or either old material affecting the retention of a new material, especially GIC, which is having a low bonding to tooth than composite, or sometimes when the caries is present under an old restorative material, or the tooth pulp is being symptomatic, or the periphery of the restorative material is not intact. However, when none of these conditions are present, leave the old material to serve as a base rather than risking unnecessary excavation nearer to pulp, which may result in pulp irritation or exposure. And however, the technique is the first is removal of the remaining caries in initial stage of tooth preparation is indicated only in following conditions. One is you can discuss it as under extensive caries, the caries involving in multiple teeth. Then second one is there are also different methods proposed for the removal of as mentioned before, that is using spoon excavators, round steel burrs at a very slow speed, then round carbide burrs with a high speed. And another thing to be noticed, frictional heat from these burr also can damage the pulp. Remember about the primary object what I've said before. Then pressure from the excavator can actually force the microorganisms into the pulp. So ideal method for the removal of the infected caries material is in which minimal pressure is exerted, frictional heat is minimized, and complete control over the instrument is maintained. So this we should keep in mind. Especially round carbide burr in slow or high speed handpiece with air coolant and slow speed, or after removal you must examine the area with an explorer, and while using an explorer you should keep in mind you should avoid the use of excessive pressure to prevent the perforation of the pulp. Then ideally removing the infected dentin should continue until remaining the dentin hardness approaches that of the normal dentin. And you can say about the removal of the old restoration is also accomplished by use of round carbide burr as a slow speed with air or air water coolant. Then you can say the water spray along with high volume evacuation is also used when removing old amalgam material to reduce the amount of mercury vapor. So these all points must be discussed under step 5. Now coming over to the pulp protection. Pulp protection is if indicated. If indicated is actually if there is a pulp protection while doing the procedure. What up should it should be done using liners or bases. Why? Because they seal the dentinal tubules. Now, pulpal irritation which is experienced during and after an operative procedure can result from either the heat from the rotary instruments and some of the ingredients from various materials, or thermal changes that has been conducted through the restorative material, or either it can be the force transmitted through materials to dentin, and another one is the galvanic shock and ingress of the noxious products and bacteria through micro leakage, which is the most common reason. And in this, liners are nothing but suspensions which is commonly used as zinc oxide, calcium hydroxide, resin modified glass ionomer, which is either applied as a very thin film which actually provides a barrier from the noxious agents and electrical insulation or thermal protection, and it is in another sense it is a sedation to pulp which stimulates the reparative dentin formation in case of a trauma to the tooth. And however, liners are not indicated if the removal of the infected dentin does not extend deeper than 1 to 2 mm from the initial depth. These are all points to be kept in mind, and these points must be noted when it comes under the pulp protection. And you can say also if the distance between the pulp, these are all points are being mentioned in our stud 1 textbook. If the distance between the pulp and pulpal floor, if it is less than or equal to 0.5 mm, then you can use a calcium hydroxide liner to stimulate the reparative dentin formation. Usually, the zinc oxide eugenol calcium hydroxide liners in thickness of usually approximately 0.5 mm, they can resist condensation forces of amalgam and provide protection against short-term and thermal changes in amalgam filling. Then calcium hydroxide liners are always covered with resin modified glass ionomer to prevent decomposition of the liner over time when it is used under amalgam restoration or composite restoration. However, it is recommended that at least 2 mm of distance should be present between the pulp and the metallic restoration, and this 2 mm separation is actually achieved by either the natural dentin that is present between them or by the use of liners or bases. Then indirect pulp capping procedure is done when an unexposed pulp with thin dentin above it. Pulp capping is done is to prevent the dental pulp from drying after being exposed or nearly exposed during cavity preparation. Then you can tell about the direct pulp capping, that is when the pulp is exposed. The material of choice is calcium hydroxide. Then the bases. Bases is nothing but the mostly the cements. Cements, which are the cements that has been, you can mention the zinc phosphate, zinc oxygenate, polycarb, oxalate, and the resin modified glass iron, which is the most common. Why? What are the features? Then you can tell about the features of resin modified. That is, they bond chemically and micromechanically. In other sense, it releases fluoride, has got sufficient strength. Another thing is it can be easily placed and contoured. And bases, in the other sense, unlike the liners, they are applied as a very thick film. Why they? Because they provide mechanical, chemical, and thermal protection to the pulp. And thickness of the base should not decrease the cavity depth too much that the thickness of the restorative material get decreased and the resulting decreased strength. So liners and bases will be applied, especially in exposed areas. They should be applied without pressure. Then comes over to the seventh step, secondary resistance retention form, where this is used. This is used when tooth preparation includes occlusal and proximal surfaces, where these areas should have an independent retention and resistance. Many preparation features which improve the retention resistance form, but the reverse is actually true. The two mechanisms of resistance, the secondary resistance and retention form, that is, one is the mechanical method, or either the placement of the etchant, primer, or adhesive on the cavity walls. So talking about, you can tell about what are the mechanical methods like retention grooves, coves, preparation extensions, skirts, beveled enamels, margins, pins, slots, steps, and amalgam pins. You can tell. In that, in detail you can tell about what are the uses of the retention grooves and coves, what is the preparation extension, what is skirts, what is the beveled enamel margins, and under beveled enamels, what are the different types of bevel you can give. Then under the pin, slot, steps, and amalgam pins, you can tell about what the different types of pins that is being used, where this slot has been used. Okay, like where these slots are being used, like it is like 1 to 1.5 mm deep box like grooves, where these amalgam pins can be used. And second type is placing an etchant, primer, or adhesive on the prepared walls. Enamel wall etching, that comes under two headings. One is enamel wall etching and dentin treatment. Enamel wall etching is actually used in restoration, which includes bonding material. Bonding material, that is in the enamel surface, which is etched with an acid, in which bonding material can mechanically get attached by the roughness that is created by an acid. Then second one is the dentin treatment, that is by the use of dentin bonding agent. And next step is, so these are all the points must be discussed under seventh step. Now coming over to the eighth step, that is finishing of the external walls. The main point to be noted is the KO surface margin or angle onto the root surface should be 90 degrees for amalgam, composite, and ceramic restoration, and it must be beveled for cast metal restoration. These are the two key points to be written under this one. And starting with the the eighth step, you should start with the definition. You must be all thorough, as I've mentioned before. Then you should talk about the objectives, that is optimal marginal junction between the restorative material and tooth structure, and second one is to get the maximum strength of the tooth and restorative material at its margin. Then you can tell about what are the factors that must be considered when finishing the cavity walls, that is direction of the enamel rods, support of the enamel rods at the dentin enamel junction and laterally, then type of restorative materials, location of the KO surface margin, degree of smoothness. Now, what are the features to be considered while finishing a tooth preparation? One is the KO surface angle. You must in detail tell about how must the KO surface angle. It depends upon the restorative material. Okay, 90 degree for amalgam and ceramic because of the low edge strength. And beveling is very contraindicated in amalgam, except it is only given at the gingival floor of class 2 cavity. But it still produces a 90 degree despite beveling. And beveling of the external walls occurs usually in cast gold and cast metals and composites also. Now, when you talk about the beveling, you can tell a slight few points on what is the purpose of beveling, especially in cast metals. You can say that the purpose of beveling is like to produce a strong enamel margin, permitting a marginal seal in slightly undersized castings, or it provides marginal metal that is more easily burnished. You must be thorough with all these points, and you can tell about what is the purpose of beveling in a composite. And what is the next, you can talk under about a degree of smoothness or roughness. This is actually done by using a high-speed handpiece, especially by burrs or plain fisher burrs or finishing carbide burrs or fine diamond burrs, and it can be achieved by hand instruments or sandpaper disc. Now, when you talk about all these high-speed handpiece is also being used. High-speed handpiece, even despite its uses, it does have side effects. You can talk about that. I mean, you can write about that. That is less tactile sensation, rapid tooth structure removal, and above these factors, they lead to extension of the overextension of the margins, grooves, walls, and rounded cavus of angles. If handpiece is used, then use a plain cut fissure burr. And degree of smoothness actually depends upon the restorative material used. Either for an inlay and, for example, for an inlay and onlay, smooth surface. For composite, rough surface is more. Slightly rough surface with amalgam, because that leads to the improvement of resistance to marginal leakage. And these all points must be discussed in finishing of external wall. This is all given in page number 313. Then coming over to step 9, that is the final procedure, that is cleaning, inspecting and desensitizing. The key points is, first is removing the visible debris with water, that is from the triple syringe, removing the moisture with air from the triple syringe. Then debris that is attached to the walls can be removed by using a explorer or a cotton pellet. And another thing is, you should not dehydrate the tooth by overuse of air to avoid the damage to the odontoblast. Then cavity disinfection. Then you can, another point is cavity disinfection, that is performed by chlorhexidine 2%. Then germicidal action by the restorative material or cements like zinc oxide or fluoride content of some material also can protect the teeth. Even corrosion from the amalgam, that will prevent the ingress of fluid and subsequent pulp damage by preventing the marginal leakage. And for non-bonding restorations, you can, desensitizers can be used, or dentin bonding can be used in bonding restorations, which decrease the postoperative sensitivity. However, these are actually used in disinfection purpose and cross-link the dentin matrix and occlude the dentinal tubules by cross-linking these tubular proteins. And cavities for amalgam should be desensitized with the solution either containing 5%, you should mention about the 5% chloraldehyde and 35% hydroxyethyl methacrylate. However, you can conclude your answer by ending up with additional concepts that require in tooth preparation. That is, first one, you can discuss it under 3 headings. That is the amalgam box or leaf tooth preparation, then amalgam tunnel tooth preparation, the adhesive amalgam restoration. These are all given in detail in page number 317.